Hello, good day everyone. My name is Kareem Seivwright and today I'll be discussing Literature Review Trauma Article 2. For the article information, the article title is Guidelines for the Management of Traumatic Dental Injuries, Number 1, Fractures and Luxations of Permanent Teeth. The authors are Anthony J. DeAngelis, Jens O. Andresen, Kurt A. Ebelesider, David J. Kenny, Martin Trope, Asgeir Sigurdsson, Lars Anderson, Cecilia Borgigian, Marie Theresa Flores, Maurice Lamar Hicks, Antonio R. Lindsay, Barbro Malmgren, Alex J. Mule, Yango Foal, and Mitsuhiro Tutsukiboshi. The name of the journal is Dental Traumatology, and the journal impact factor has an H index of 77. The date of publication is January 7th, 2012, and the type of article is literature review, expert opinion. The major topic is traumatic dental injuries, and the major purpose is to delineate an approach for the immediate or urgent care of traumatic dental injuries known as TDIs. It is understood that subsequent treatment may require secondary and tertiary interventions involving specialists, consultations, services, and or methods not always available to the primary treating physician. In the case where the data did not appear conclusive, recommendations are based on the consensus opinion of the working group, followed review by members of the IADT Board of Directors. The IADT does not and cannot guarantee favorable outcomes from strict adherence to the guidelines, but believe that their application can maximize the chances of favorable outcome. These 2012 guidelines in this journal will appear in 3 parts. Part 1, Fractures and Luxations of Permanent Teeth. Part 2, Avulsions of Permanent Teeth. And Part 3, Injuries in the Primary Dentition. These guidelines offer recommendations for the management of some TDI cases, but not comprehensive information seen in some texts or scientific literature, like the Dental Trauma Guide. One must use their expertise to decide which angulations and projections should be used, but the following are recommended. Periapical radiographs with 90-degree horizontal angulation and central beam through the tooth. Occlusal views, periapical radiographs with lateral angulations from a mesial and a distal aspect of the tooth. Computerized tomography, CBCT, is the latest technique and is the best in terms of visualization. Diagnostic imaging. Periapical radiographs are useful since they can show not only the crown but the root structure, as well as up to 2 to 3 millimeters of the surrounding bone. This is key in trauma since fractures can either be in the crown, extend to the root, or even involve the alveolar bone. The occlusal radiographs are useful in trauma since they can be used in instances where the mouth opening is limited. It can be used for children who are uncooperative and cannot tolerate a film holder in the mouth. Cone beam CT is very useful since it provides a 3D image of the area. This is very useful in identifying fractures and displacements. There is no need for any intraoral film holder, and magnification is also possible with this view. It is currently considered best practice to maintain The repositioned tooth in correct position provide patient comfort and improve function. The use of systemic antibiotics has not proven to increase the outcome of root fractured teeth, but it is of the clinician's choice based upon expertise if it is needed, as well as patient health status. Sensibility tests are used to determine pulpal health status. In most cases, when this is done immediately after the trauma, there is no response. At least two signs and symptoms are needed to give a pulpal necrosis diagnosis. Majority of the TDIs occur in children and teenagers. The immature permanent tooth has considerable healing capacity when it comes on to TDIs. This is achieved through pulp therapy to preserve the pulpal tissue until root development is completed. The mature permanent tooth that receives a severe TDI with pulp necrosis being anticipated can be salvaged by preventative pulpectomy as the root continues to develop. Pulp canal obliteration happens mostly in teeth with open APCs, which have suffered a severe luxation injury. It is usually indicative of ongoing pulp vitality. Extrusion, intrusion, and lateral luxation-based injuries have a high incidence of PCO. Subluxated and crown fractured teeth can also show PCO, but with less frequency. PCO is also a frequent finding in following root fractures. We can see here a table from the study. It shows a series of different injuries, dental trauma specifically, and how they will be managed. We'll focus mainly on the treatment as well as the favorable and unfavorable outcomes. For infractions, in case of marked infractions, etching and sealing with resin to prevent discoloration of the infraction lines, otherwise no treatment is necessary. For a favorable outcome, asymptomatic positive response to pulp testing is desirable and continued root development in the immature tooth. Unfavorable would be symptomatic negative response to pulp testing, signs of apical periodontitis, as well as no continued root development in the immature tooth. Endodontic therapy appropriate for a stage of root development is indicated in these unfavorable situations. For enamel fractures, the treatment would be, if the tooth fragment is available, it can be bonded to the tooth. Contouring or restoration with composite resin depending on the extent and location of the fracture. For a favorable outcome, asymptomatic or a positive response to pulp testing, continued root development in immature tooth, those would be very good. Unfavorable, as before, symptomatic, negative response to pulp testing, and signs of apical periodontitis as well as no continued root development. For enamel dentin fractures, treatment would be, if the tooth fragment is available, it can be bonded onto the tooth. Otherwise, perform a provisional treatment by covering the exposed dentin with glass ionomer or more permanent restoration using a bonding agent and composite resin or other accepted dental restorative material. If the dentin is exposed though, showing 0.5 millimeters of pulp, which would be pinpoint bleeding as well, place calcium hydroxide base and cover with a material such as glass ionomer. A favorable outcome, once again, just as before, asymptomatic positive response to pulp testing and continued root development. Unfavorable would be symptomatic negative response to pulp testing and signs of apical periodontitis, no continued root development. In the case of enamel, dentin, and pulp fractures, treatment would be for young patients with immature, still developing teeth. It is advantageous to preserve the pulp vitality by pulp capping or partial pulpotomy Also, this treatment is a choice in young patients with completely formed teeth. Calcium hydroxide is a suitable material to be placed on the pulp wound in such procedures. In patients with mature apical development, root canal treatment is usually the treatment of choice, although pulp capping or partial pulpotomy may be selected. Favorable, once again, asymptomatic positive response to pulp testing and continued root development. Unfavorable, symptomatic negative response to pulp testing and signs of apical periodontitis and no continued root development. For crown root fractures without pulpal exposure, in an emergency situation, treatment would be of a temporary stabilization of the loose segment to the adjacent teeth can be performed until definitive treatment plan is made. Non-emergency situation would be fragment removal only, removal of the coronal crown root fragment and subsequent restoration of the apical fragment exposed above the gingival level. Fragment removal and gingivectomy, sometimes osteotomy. Removal of the coronal crown root segment with subsequent endodontic treatment and restoration with a post-retained crown. This procedure should be preceded by gingivectomy and sometimes osteotomy with a osteoplasty. Orthodontic extrusion of apical fragment as well. As we said before, asymptomatic positive response to pulp testing and continued root development is what one would want. What you wouldn't want is symptomatic negative response to pulp testing, signs of apical periodontitis, and no continued root development. For crown root fractures with pulpal exposure, there is emergency and non-emergency treatment. Emergency treatment. As an emergency treatment, a temporary stabilization of the loose segment to the adjacent tooth. In patients with open apices, it is advantageous to preserve pulp vitality by partial pulpotomy. This treatment is also the choice in young patients with completely formed teeth. Calcium hydroxide compounds are suitable pulp capping materials. In patients with mature apical development, root canal treatment can be the treatment of choice. For non-emergency treatment alternatives, fragment removal and gingivectomy, sometimes osteotomy, removal of the coronal fragment with subsequent endodontic treatment and restoration with a post-retained crown. Unfavorable would be symptomatic negative response to pulp testing, signs of apical periodontitis, and no continual root development. And favorable, once again as well, would be asymptomatic positive response to pulp testing and continued root development. For a root fracture, treatment would involve reposition, if displaced, the coronal segment of the tooth as soon as possible. Check position radiographically and stabilize the tooth with a flexible splint for 4 weeks. If the root fracture is near the cervical area of the tooth, stabilization is beneficial for a longer period of time, possibly even up to 4 months. A positive response to pulp testing, as well as signs of repair between the fracture segments, would be favorable. Unfavorable would be symptomatic negative response to pulp testing. Extrusion of the coronal segment and radiolucency at the fracture line are not good. For alveolar fracture, treatment would be reposition any displaced segment and then splint, suture gingival laceration if present, and stabilize the segment for 4 weeks. Favorable outcome would be positive response to pulp testing, no signs of apical periodontitis. Unfavorable would be symptomatic and negative response to pulp testing. For concussions, treatment is none and monitor the pulpal condition for at least 1 year. Favorable, asymptomatic positive response to pulp testing, continued root development in immature teeth, as well as intact lamina dura. Unfavorable would be symptomatic negative response to pulp testing, false negative, possible up to 3 months, no continued root development in the immature teeth. For subluxation, normally no treatment. However, a flexible splint to stabilize the tooth for patient comfort can be used for up to 2 weeks based on the clinician's judgment. Favorable would be asymptomatic positive response to pulp testing and a false negative is possible up to 3 months. Continued root development is also good. And once again, unfavorable, symptomatic negative response to pulp testing, false negatives are possible up to 3 months, and external inflammatory resorption would not be good. Extrusive luxations. Treatment would be reposition the tooth by gently reinserting it into the tooth socket, stabilizing the tooth for 2 weeks using a flexible splint. In mature teeth where pulp necrosis is anticipated or if several signs and symptoms indicate that the pulp or immature teeth become necrotic, root canal treatment is indicated. Favorable outcome, asymptomatic clinical and radiographical signs of normal heel periodontium. Positive response to pulp testing. Negatively, you'd see symptoms and radiographic signs consistent with apical periodontitis. Negative response to pulp testing. If breakdown of marginal bone, splint for an additional 3 weeks. For lateral luxation, treatment would involve resorption, reposition of the tooth digitally or with forceps to disengage it from its bony lock and gently reposition it into its original location. Stabilize the tooth for 4 weeks using a flexible splint and monitor the pulpal condition. Favorable outcome would be asymptomatic and clinical and radiographical signs of normal or heel periodontium. Positive response to pulp testing and a marginal bone height corresponding to that seen radiographically after repositioning. Unfavorable would be symptoms and radiographic signs consistent with apical periodontitis. Negative response to pulp testing. If breakdown of marginal bone, splint for an additional 3 to 4 weeks. Intrusive luxation. Teeth with incomplete root formation, you would allow the eruption without intervention. If no movement within few weeks, initiate orthodontic repositioning. If tooth is intruded more than 7 millimeters, reposition surgically or orthodontically. For teeth with complete root formation, allow eruption without intervention if tooth intruded less than 3 millimeters. For a favorable outcome, one would want the tooth to be asymptomatic, and unfavorable, symptomatic, and it would be locked into place due to ankylosis. For the level of evidence of the article, it is within level 5 since it is an expert opinion. This makes it suitable for the purpose of education but would not be relied upon solely for treatment planning. One can conclude that this article is very detailed in its efforts to guide treatment planning of TDIs. Without sufficient evidence founded upon case-controlled studies or randomized trials, it has a higher chance of being susceptible to bias, unfortunately. These are my references, and if there are no questions, thank you